The conference has been muted.
Good afternoon and welcome to Strategy Solutions webinar on measuring and evaluating outcomes and impact using a logic model approach. This is a basic overview of how to think about using logic models to start the process of measuring and evaluating the outcomes and impact of community health improvement strategies that might be identified as part of a community health needs assessment or a community health improvement activity. I am Deb Thompson, and I'm the president and founder of Strategy Solutions. A little bit about our company for those of you who may not be very familiar with us. The mission of our company is to create healthy communities. We're a small, kind of a boutique consulting firm located in Western Pennsylvania. We have offices in Erie and in Pittsburgh, and our practice was actually born out of my work about 25 years ago in the community health movement in northwestern Pennsylvania. And I was a hospital planner at that point and described myself as a recovering hospital planner. Please don't hold that against me. But what I've learned through my 10 years of being the spiritual leader of community health in our local community, that hospitals alone were never going to solve the community health problems and were not on their own going to create healthy communities. And I started Strategy Solutions because I really felt at that time that it was important to understand how the other sectors in the community government sectors and the private sector wealth creators, actually worked together to create that healthy community, and intentionally grew our practice in economic and workforce development so that we could gain an understanding of how those systems could work together to help create healthy communities, and have been kind of at that ever since. Now we're gathered here today to talk about how to identify outcome and impact measurements related to community health improvement and other programs using that logic model approach. We're going to talk a little bit about how you can assess your strengths and needs related to outcome and impact measurement and evaluation, and educate the participants on how to connect the dots between what you're already doing and what you could be doing to measure and evaluate your work. And I do want to mention, and I'll bring this up again at the end, I'm going to do a little commercial for another webinar we're doing later this month on how to take the things that you've identified as outcome measurements and actually create measurement tools to measure them, and in some cases how to automate those measurements, and what to do to implement the measurement process itself. Today's workshop is more kind of an overview and to help you get started to think about that process and how to really use that logic model as a guide to help you identify what those outcomes measures need to be. But the next webinar is really going to talk more specifically about, well, how do we actually do the measurement and how do we actually track indicators? Because many people are in fact tracking things by hand and thinking about automation of their indicators as using an Excel spreadsheet. And that, in my view, that's still using them by hand, doing it by hand. So we want to talk about doing somewhat of a different approach. Now, as you get started on thinking about your measurement and evaluation process, there are some key strategic questions that you want to start from at the beginning of your process. You want to be asking yourself the question first, what are we trying to accomplish through the programs? What's the goal? What do we expect to have happen? And also, how important is measuring collective impact of efforts with community partners? For example, we've worked in various communities where there are many different partners doing the same or similar kinds of obesity programs, for example. I'm going to talk about one example of that kind of an effort in a few slides. What are you doing to create consistency of those measures across various programs so you can actually put that data together? if folks use the same questions on their evaluation survey, for example, you can start to compare data across programs. How important is population health? And how do our program implementation strategies tie with population health strategies? Are we making that connection? To what extent are you addressing the social determinants of health as part of your program implementation strategies? Because those might be important as part of your outcomes measures. To what extent are you appropriately capturing all of the community benefit investments? This is really an important question for hospitals, because what we've found in working with a number of different hospitals on community health implementation strategies, that there is a ton of work going on out there where hospitals, nonprofit hospitals, are doing intervention strategies where they're not getting reimbursement or paid, that they're working in communities, and they're doing it as a community benefit, but they're not counting the investment in those programs as community benefit dollars on their tax forms. Now, what we advise people is to really try to make those two things congruent, that you are actually capturing how much you're investing in terms of dollars in those programs, that you're not just doing free stuff for folks in the community. You also want to look at to what extent are you evaluating the degree to which your practices are consistent with, for example, a Catholic identity matrix if your organization is a faith-based organization. We're familiar with a number of faith-based organizations, some that are part of the Catholic Health Network, that are looking at how consistent are their programs with that Catholic identity or that faith-based identity that they have. And then to what extent are you incorporating your mission into your programs? These are all important strategic questions that you want to ask at the beginning of the process. You also want to talk about, are you aligning your population health and your value-based payment model work? Because oftentimes, depending on what your specific strategies are, the best outcomes of some of your intervention strategies, for example, might actually be your readmissions. A lot of hospitals are doing readmission strategies to help improve their reimbursement or to mitigate their losses on populations, especially if they have an accountable care organization or an ACO. They're trying to mitigate their losses on high risk and high utilizer patients. Those strategies to do that are often community health improvement strategies. They often relate to our better health and prevention strategies that happen out in the community. Maybe we should connect those things with our needs assessment. Our patient engagement activities and really addressing medical and social needs as part of that, and looking at, are we doing anything to create cross-sector collaboration or to impact advocacy or policy in a community or with our payers in a community? All of those efforts can be part of our implementation strategies, should be part of our community benefit, and should be things that we're assessing the outcome and impact of. We want to be thinking about that all together. We also want to be thinking about kind of where we are in what I call the community health improvement evolution. There's a lot of folks that are doing things to educate different populations, to educate the community, to focus on prevention and addressing chronic disease and high-risk patients. Where are your strategies kind of on this evolution, and are you doing anything collaboratively to impact the health status of the community? Because we want to be able to capture the outcomes and impact of those things as well. I mentioned earlier that we would be looking at those efforts that might have some type of collective impact, because this is an important question that when you want to ask yourself as you start your data collection. This is an example that comes from Lancaster General which is part of Penn Medicine, the health system in the southeastern Philadelphia area. They've been working for a long time on a multi-level approach to healthy weight and have intervention strategies going on in their community at the public policy level. For example, the director of planning actually sits on the planning committee for the council and for the municipality of Lancaster to help influence public policy to create more walkable communities and healthier communities. They have intervention strategies happening at the community level where lots of different community agencies are working to improve health status and to improve and to help people get closer to a healthy weight. They have organizational strategies where the organizations are targeting their employee health initiatives to focus on healthy weight, including at the hospital and within the organizations that are other community partners. They're doing interpersonal types of interventions and they're doing individual kind of interventions. And I bring this up as an example because part of their data collection effort is to look at how do we collect data across all of these different initiatives to tell us whether or not we're making a difference in the impact on those programs. As you begin with the end in mind, I mentioned that one of the strategic questions is think about the current condition and what the goals are related to those. And as you think about using a logic model approach to outcomes measurement, you also want to have an eye toward your evaluation process and what the evaluation process itself looks like. And measuring the outcomes and figuring out a measurement system for the outcomes is part of the work that's done on the pathway to improving your evaluation capability. So if you want to improve evaluation, you want to identify the current condition you want to change and those program goals. You want to develop a logic model. And I'm going to talk in a few minutes about, well, how do we actually create a logic model and show you some examples of logic models for programs that we see people doing frequently. Talk to IT professionals about how to create data collection and reporting systems through electronic software where it's possible, through an electronic health record or through some other data collection mechanism that you might have available. Implement an evaluation process and develop a progress report. And actually discuss and document what's working and not working. What I've found with healthcare professionals, whether they're working in public health or they're working in hospitals or in a physician office, medical and public health professionals are doing evaluation all the time in their heads. They're thinking about how do we improve what we're doing. They're talking out loud and making statements that are evaluative in nature, and they're improving their processes as they go along. The gap there is that they don't pick a point in time where they sit down and write down their conclusions and create an action plan for how they're going to improve what they do. Most of the evaluation efforts are actually done on the fly and informally as part of the work that you're doing. You don't recognize it as evaluation. So what I'm recommending to you is that you stop, you take a point in time, and you sit down and document what's working and what's not working and your plan to make changes. Like I said, most people are doing that in their heads. They just don't write it down. And I'm also encouraging you to when you write it down, to put it in the context of an overall goal and to help connect the dots with other efforts that might be going on within a community. And as we talk about how do we start looking at a logic model and using a logic model approach, I'm actually going to use an example that I talk about frequently from WellStar Health System, actually West Georgia Medical Center that's part of the WellStar system. They've actually done a nice job of connecting the dots of their various community health activities and doing their intervention strategies as part of their overall goals, not only for their hospital and the health system, but also for their cancer program. And they've actually gone a step further than a lot of organizations do, and they've connected their evaluation process to their cancer accreditation, because the Commission on Cancer actually requires certain outcomes to be tracked as part of the accreditation process, but we don't often, again, connect the dots back to, well, we have these prevention programs that are part of our community benefit, that we're doing outreach and education and screening to try to get people in the door. Well, how does that all get connected? I'm going to talk about that in the context of this overall goal, which in Troup County, Georgia, is to reduce the incidence and prevalence of chronic diseases, improve chronic disease management at the same time. So what do you do to get started? You develop a logic model. A logic model is a graphic representation of a program, and it's a tool. It's a tool to help you do and identify outcomes and impact. And once you get the hang of it, it's actually very easy to use. And one of the resources that we'll send to you is one of the slides here, which is kind of my cheat sheet for logic models. I keep it on my desk, or I sort of carry it with me whenever we're working with a client on how to identify outcomes and impact, because it's the guide to help you figure out what goes into what box. And it's easy to do once you get the concept. So what is a logic model? It's a roadmap of inputs, outputs, and outcomes. And here's a very simple example of a logic model. I'm hungry. That's the condition I want to change. My activity is that I get food. My short-term outcome is that I eat the food, and then I feel better. That's my medium-term outcome. That's a very simple logic model. Here's another way of looking at a logic model. My output measures, or my process measures, are answering the question, are we reaching who we should reach? The number of people we reached. Program strengths and weaknesses are output measures, or feedback or satisfaction. We see a lot of people use patient satisfaction or participant satisfaction as an outcome measure. It is actually not an outcome measure. It is an output measure. A lot of people don't realize that. The outcome measure, especially when you're doing some type of education program or some type of intervention strategy, the outcome measures are related to what knowledge, attitude, or behaviors actually changed as a result of the program that you're doing. Those are the outcomes. People change their behavior. People change their attitude. And in the very short run, intent to change behavior is also a short-term outcome. The impact is, what are the long-term changes that are the result of the changes in the program variables? And then my favorite one is the new impact question, because this is what a lot of funders are asking and a lot of payers. Well, how does this program save the system money? Well, yeah, you might be making a difference here, but the ultimate test is this going to actually meet the triple aim? Not only save money, but is it going to improve health status over time, and is it going to improve quality of care? That's really the triple aim, is what population health is striving to achieve. Here is my cheat sheet, this one right here, to build a logic model. And this is sort of the generic version of any logic model that can be used. And I like it for that reason. The inputs are the things, what we invest. It's staff, volunteers, money, equipment, technology, the research base. Our outputs are the activities, what we do, and who we reach. So we're doing some type of activity in our program. We're training, we're teaching, we're delivering some type of service. We're also reaching people. So the number of participants in a program is actually an output. The number of customers, customer satisfaction is an output. Short-term outcomes include things, generally things related to learning, knowledge, awareness, attitude, skills, opinions, aspirations or intentions, or short-term outcomes. The medium-term outcomes are action, a behavior change. I've made a decision to do something different. And then over the long run, it's going to change my condition where I have improved health or improved well-being or lower cost or some other longer-term outcome. As you notice on the bottom of here, I also have these, there's some things at the bottom labeled in purple called macro. These are measures that can be used if you're doing some type of what I'll call a macro approach in the community or a public policy approach where you're attempting to shape public opinion about a particular process or partnership or whatever. And the example that I'll use is Mothers Against Drunk Driving. That initiative, if you really look at it, actually had a multi-pronged approach. Not only did they educate students about the ills of drinking and driving, they also took a policy perspective and did advocacy to change legislation. So some of their outcomes included a policy change. It included social action. It included changing police regulations and things like that. So there was a lot of, who we reach are people like agencies and decision makers and politicians. It's not a program participant or a client. So I just want to make that distinction that some of your outputs and outcomes might actually be process measures to reach out and educate people and get legislators, for example, to introduce a new piece of legislation that might better enable your work. That's an example of a macro approach. Here's actually a simple example of looking at a logic model for maybe a clinical program, for example. You have inputs, staff, volunteers, money, equipment, technology. What we do, we could be screening, we could be doing lab tests or education or referral. Who we reach, the number of program participants. Short term, the number and percentage of people who come back for test results. We worked with a lot of people who do, blood screenings or lab tests as part of their intervention strategies. Well, if people are coming back for their test results or going to the doctor to get their test results, that's a short-term outcome. Or increase in knowledge or intent to change behavior. Those are short-term. In the medium term, the number and percentage of people who schedule or attend a follow-up with a doctor or have a diagnosis based on the test results or get into some type of care management initiative. And then, over the longer term, it could be that cancer incidence is decreased, quality of life cost savings associated with these decreased interventions. I include these two next slides in this presentation because a lot of people are doing health fairs and they count the number of people who come to health fairs. And that's lovely for an output measure, but, well, it's not an outcome. Well, how can you measure that? Well, you can actually measure, especially if you get the same population coming back year after year, you can ask people if they came last year and ask them what they learned and if they did anything about it. You can also ask people how useful they felt the information was of the presentation that you did at your health fair. You can also ask people what their intent to change their behavior is. How likely are they to follow the advice or guidance presented today or follow up with your doctor for more information? So that percentage of people who are very likely to do something, that's a short-term outcome of an education program. Going back to my cancer example, one of the intervention strategies that a lot of communities are doing is jumping on the bandwagon of the 80% by 2018 goal of the American Cancer Society to get 80% of patients 50 to 75 years old actually having colorectal cancer screenings. That's the national goal for the Cancer Society. Now, this is, again, back from the example of WellStar. Over the next, I think this was a 2016 goal. Their initiative was to have at least 50% of the patients that were eligible in that age range to address that goal. And they actually started with one physician practice. And the percentage of the pilot practice before the pilot started was only 11%. And they didn't set it at 80 because they felt that was just too high. And after getting started, their ongoing practice return percentage from that pilot practice was 74%, and they actually got it up to as high as 90%. They also were working on decreasing the time from diagnostic mammogram to biopsy, and were also trying to increase the number of people who were screened and then went on to receive cancer care if they had some type of issue. And here's an example, and this is kind of a collection. These are not, some of these are from West Georgia Medical Center, but these are kind of a collection of examples of different outputs and outcomes and impacts that we've seen from various cancer intervention strategies. So outputs would include the number of people who are screened. Outcomes would include short-term, number of people who receive a voucher, the number of people who actually complete a breast exam, number of people who schedule a mammogram, and then how many people actually go to the mammogram. Those are all different short and medium-term outcomes. And then the impacts might be the number and percentage of people by stage who were diagnosed with cancer, and then dollars saved by screening and diagnosing at an earlier stage. The length of time, the number of people who are readmitted, the number of people who receive treatment within the standard guidelines, and then the number of people with 5-year survivorship, and actually track over time. So these are examples of how they fit into a logic model. Here's another way of looking at sort of laying it out in the logic model format. The inputs, staff, facilities, equipment, activities, what we're doing, outreach, screening, our output, our short-term outcomes, looking at, the number of percentage of people who come back or who actually complete the screening, what they are over the medium term and what they are over the long term, including measuring those cost savings associated with lower incidence rates. The next couple of slides are actually different examples of logic models that are done for different types of programs that kind of give you an example of how it's done. Like this is sort of a recommended logic model for a hospital ethics program, which if you work in a hospital and you have an ethics program, there's a lot of similar activities that are done and similar programming that are done by ethics committees in hospitals, including developing education, developing and delivering training for the consultant teams that run the ethics programs, consulting on ethics-related issues. The number of who we reach would be the number of percentage of staff who are trained as consultants or who actually learn about the issues related to ethics. And the outcomes then are things like the number and percentage of new hires that actually are able to recognize the ethical principles at orientation, and you can measure that at the end of an orientation program. The number and percentage of clinicians who attend training who say that they are likely to use those principles later. And then you can do things like track the number of ethics referrals and the number and percentage of decisions that are made according to ethical guidelines. And you might say, well, how do I measure that? You could actually have an indicator put on the medical record for some member of the clinical team or the ethics team to evaluate that based on a case review, and then, basically make it an indicator that you can query and track. Another example, and this is actually a real example from Christus Health, which is the St. Patrick Health System, but I included it in here as a example of a school-based health center logic model example, because I know lots of hospitals and organizations are now doing school-based health centers. So, well, what kind of things do we track as part of a school-based health center? Well, what you might want to do is track the number and percentage of people who are part of that program. How many kids are actually getting screened, what percentage of them are sharing information and referrals, how many of them are showing up, are any of the students identified with chronic diseases, because I know a lot of school districts, at least in Pennsylvania, if they have students that have like diabetes or several other health conditions, obesity, those are actually reportable. So you can actually track this data and you can report on it. And then if there's other intervention strategies, that the number and percentage of students who are actually seen in the clinics who have improved grades, people who have run these programs, you can compare the grades of the students who don't access health care through the center with those who do, and see if there's any differences. You can also look at, have children lost weight? Is there any marked improvement in their health status or in their conditions based on your intervention strategies? I also included another example in this slide deck of outcomes related to primary care access, because I know a lot of health systems have these types of improving access to care on their implementation strategies, and aren't necessarily met. They might talk about the number of people that they sign up on the marketplace, for example, but are in fact they tracking the number of people who they're making referrals to, and did the person, let's say somebody, a lot of times the primary care access folks are actually working with patients who show up to the ED with a primary care diagnosis. Well, they make a referral to a clinic. Did the person actually show up and schedule an appointment at the clinic? And I've seen different programs where they're actually doing the scheduling of a person at the clinic. So you want to be able to think about, well, what happens to these people, and did it make a difference in terms of their health status? But one of the long-term measures is going to be, did it impact our emergency department utilization rates, and did it go down? So just some examples for you to look at for your particular questions or for your particular programs. And as you think about, I'm going to sit down now and develop a logic model. What do I want to ask myself? As I said in the beginning, here's the questions you want to ask yourself. You start with the goal. What am I trying to accomplish? There are some people that say you put the long-term goal in first for the long-term outcome and then sort of work backwards. What activities are happening? You want to ask yourself, are there any activities that are missing? Because we've done logic model development processes with clients where they have an expected outcome, but they've got no activity in their program that actually would achieve that outcome. And I'll give you, my favorite example is a local one from our Habitat for Humanity nonprofit. It's a housing organization. this was years and years ago. We were working with them on developing logic models, and one of the long-term outcomes that they wanted out of their programs was for people that own their houses to have better financial literacy. And it was an aha moment for the folks that were there talking about the program, because they said, well, we got nothing in our program that actually teaches financial literacy to our clients. Ding, 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 ding. That was an aha moment for them, that they actually had to change their activities to get the outcome that they wanted. How do you measure the activities themselves? Those are the outputs. And then what knowledge, attitudes, or new skills, aspirations happen because of the activities that you do. And what I found is that as I interview clinicians, most clinicians can tell me what people are doing and what happens with each individual person that they know that participates in the program. The problem is that they're actually not tracking those things. They don't track them. They know them intuitively. They talk to people about them, so they have the outcomes anecdotally. They just don't track them. If you ask yourself these questions and identify those indicators in your logic model, well, now I can sit down and say, how do I measure this stuff? And then what change in condition happens because I changed an attitude and then I changed behavior, that becomes my long-term outcome. And then once I have that, I can start to think about, well, how do I hardwire my data collection? And I send people back to their IT friends. We want to ask, does the outcomes data already exist somewhere? What we found is that in a lot of cases, we're collecting data on meaningful use. We're collecting data because it's a quality measure, but we're not connecting it back as a measure of something that we're doing on the front end. And that data exists. My colleague Kathy and I were recently working with a group of chaplains on the spiritual care teams of a faith-based organization about, well, how do we measure the outcomes of the work of the chaplains? Well, interestingly enough, we found out that their medical records had they had ways of capturing their activities, they had ways of capturing their outcomes, but there was no report created from the EMR on the outcome field. And what we found out was they would have to go back to the vendor to actually request that to be created, but the data was there. They were already collecting the data, they just weren't reporting it. So you want to say that. Is the data there? Many indicators are already reportable quality measures, and if the data doesn't already exist, then you say, how do we create a process to get it? Sometimes all you have to do is add a field. Sometimes you have to take a text field from the nurse's notes and make it a queryable field. Now that may sound like a hard thing to do if you're a nurse and you don't know the information system, but most hospitals or health systems, and even in some cases public health departments, have technicians that know what's in the data if you have a data collection tool. Or you can start to create one of your own, even if it is an Excel spreadsheet. Because if you've not done any type of formal data collection before, an Excel spreadsheet is better than nothing. It's better than the tick sheet on the nurse's desk. It's not as good as tracking through an electronic medical record, but sometimes we have to crawl before we walk and walk before we run. We got to start somewhere, okay? We got to start somewhere. And then if you want to improve your evaluation capability, we recommend that you identify a steering committee or a program evaluation work group if one doesn't exist.
Thanks, Mom.
Okay. Identify stakeholders, your program staff, participants, or others that you want to gather input from related to your needs and outcomes. You want to develop evaluation surveys, review your outcomes and impact data, as well as any other evaluation input. And as I said earlier, document the conclusions from the data review and input. People are doing this stuff. We see it all the time. We just don't see folks documenting it and writing it down. And then identify ideas and an action plan to improve the program. Here's our favorite sort of generic evaluation process schedule. And this is a little bit even more robust than what I'll call the simple version, because sometimes you want to collect data from other people that know about the programs. So throughout the fiscal year, we implement the programs and establish a process to collect the outcomes data. We start with a logic model. In the month after a fiscal year, we compile the data that we have. We'd look at it. We would finalize evaluation meetings, and oftentimes we'll gather feedback and input from other stakeholders that know about what was going on. Like, for example, if we're looking at a cancer program, for example, we're looking to evaluate what's gone on with the cancer program, we don't just look at the data. We'll actually talk to the clinicians about what they see and what they think the additional needs are other than what we're already working on, and it helps to create new goals for the upcoming year. We actually set a date to convene people, our steering committee or our project team, to actually sit down where we talk about the data and draw conclusions, and then we'll prepare a statement. If it's a hospital and we're actually doing the formal evaluation for the community health needs assessment, we'll actually prepare a little summary report that can be attached to the Schedule H regarding the activities, outcomes, and impact. So in summary, if you want to improve your outcomes and impact measurement, use a logic model framework to walk you through the process of identifying activities, outcomes, and impacts. Sit down with a little logic model and just fill it out. And once you've done it a few times, it becomes easier. Practice actually makes it easier for you to do it. But you want to start there. You want to identify the appropriate tools to gather outcomes and impact data. And again, I'll do a little commercial for our next upcoming webinar that will talk about, well, how do we actually do that? Okay, now I got my logic model done. How am I going to measure? How am I going to actually create a measurement system for everything that's in that logic model, or pick certain things to do a measurement system for? I actually collect it and then conduct that annual evaluation. So with that, I'm going to say thank you very much for your participation. And if anyone has any additional questions or any questions, I'd be happy to stay on the line for a few minutes and answer them. And it would be helpful if
the conference has been muted. The conference has been unmuted.
Helpful to unmute the folks on the phone if I want you to ask me questions. Anyone have any questions? I do see one question that's come in via the chat feature that I'll read and share. The question is, if I've never done this before, how do I get started? I'll go back to think about who are the best people to be involved with looking at a particular program or the outcomes, and then put that group, call that group your steering committee, so that you get them, so you work with them together as a group to start the conversation about let's put a logic model together. Let's work on a logic model together. That's probably the best way for you to get started in a process like that. Any additional questions from anyone? Okay. Another question is, can I talk a little bit about how you set expectations so for those who want to see big impact numbers, particularly for projects that are smaller and more focused? That's a very good question. I think that if a program is small and focused to begin with, the best thing to do is to start measuring and evaluating the outcomes and impact of that particular program. I see a lot of folks that automatically jump to, well, I should be impacting obesity rates in my county because that's what I should be doing, but I'm running a program that only serves 25 people. And I think part of the answer to that is you should only be thinking about the expectations related to the program that you're offering and trying to measure and evaluate the program that you're offering and not expect to move the needle on everything. I've seen, like, obesity rates is a good example. Probably 4 or 5 years ago, I saw a really incredible presentation at the ACHI conference from this, and I don't remember the name of the person who did the presentation, but she showed this graph of obesity rates in the county that they were working on intervening in. And they had something like 42 different organizations working on obesity rates, doing similar weight reduction and exercise programs. And it took them 9 years. And they were tracking through community assessment surveys or community health assessment surveys. They were tracking obesity rates at the community level. So that took a long time. And they had a lot of different people working on collective impact together. So if you really want big impact, but you have a small program, maybe that's your opportunity to talk to collaborators, similar to my example from Lancaster Penn Health. You get other people, you get other collaborators in the community working on similar measures, and now we can start to measure collective impact. And over time, the more collaborators you get that are doing similar programs, now you can start to say, over time, we can perhaps impact obesity rates across a county or across a region. In the meantime, you're better off really focusing on the population that you're serving through your program and trying to make statements or evaluate what your program intervention is doing for the population that your program is serving, and not try to be all things to all people. Because you can't, it's unrealistic for you to say, I'm running a program that serves 100 people, and I'm going to move the needle in, of all of the people who live in Washington County, for example. Okay? So a lot of it depends on the size and the scope of your program and whether or not you have collaborators and you're attempting to do some type of collective impact. That was a good question. I hope I answered it. Okay, good. Any other questions? Okay, hearing none, I'm going to stop the recording. And thank you for your participation today.